And warm welcome. I hope you have been finding this review in oral medicine very engaging. Before we dive into presentation, I would like to extend my gratitude to Dr. Seema and the organizing team. Thank you for this opportunity. It's been a long day and I hope you find this lecture both informative and enjoyable. See, this is the quote by Dr. Lipton. And those who want to study MRI in very much detail, there are good lecture series and videos of MRI introduction by Dr. Michael Lipton. They are very helpful to understand the physics in depth. Yes. So looking at this jaw slice, you will notice that tissues like bone, muscles, fat each appear different because they interact with light in unique ways. So now can you someone explain what MRI is and what we aim to detect with it?
Ma'am, the students are disabled for the mic.
Okay.
If you
So
want, we'll tell them to put them in the chat box.
no, that's okay. I won't be able to say it. That's okay. So
Okay.
so what we are really looking for with MRI is contrast. The cone principle of MRI is contrast, the ability to tell one tissue from the other. This is especially important for identifying soft tissues and spotting any malignancies within the tissues. So what do we focus in MRI and other imaging technique? Differentiation and contrast. Main objective of MRI is to non-invasively identify and visualize various tissues. Now, MRI is an expansive and intricate field that cannot be thoroughly explained in just one lecture. In this presentation, I will focus on the essential concepts of MRI and its specific applications in maxillofacial imaging, aiming to provide a clear and fundamental understanding of this fascinating technology. So I'm Dr. Priyanka Sakhavalkar. We met 2 days ago also. I am having dedicated oral medicine practice in Nasik as DiagnoSure Oral Medicine and Radiology Clinic. And I'm also working, I have also a work experience from India and UK. In this presentation, I will focus on the fundamentals of MRI physics, including both conventional and advanced MRI techniques. As dental radiologists, we often encounter challenges due to limited understanding of the underlying science of MRI. Given the essential role of MRI in contemporary practice, gaining a solid grasp of its principle is very crucial. While anatomical knowledge can be acquired through textbooks, understanding MRI physics will provide valuable insights into applying this technology effectively. This includes determining when to utilize conventional MRI and when we can extract some additional information of MRI. Starting with the introduction and basics. So first, what is MRI? Magnetic resonance imaging, that is MRI, is an advanced non-invasive imaging technique which was used to create a detailed images of organs and soft tissues inside the body. It works by using strong magnetic fields and radio waves to generate images. Particularly, it is useful in distinguishing soft tissues. In MRI, the key factor that allows us to identify different tissues is contrast, like I said previously. So what we look for in MRI, first is soft tissue contrast, differentiation between muscle, fat, potential lesions and tumors, all that we can see non-invasively without use of any ionizing radiation. Then pathology detection, the identifying areas that deviate from normal tissue patterns that are often seen because of the contrast. And this ability to clearly visualize and distinguish these tissue types is particularly important when trying to detect abnormalities. Even when in malignancies where subtle changes or tissue structure can indicate the presence of disease, MRI plays a very crucial role. So there are so many imaging modalities. Why MRI? MRI is nowadays preferred modality because of several compelling reasons. First, non-ionizing radiation. Unlike CT scan and X-rays, MRI uses non-ionizing radiation, making it safer for repeated imaging. and it reduces long-term risk associated with radiation exposure. High tissue contrast, it provides excellent differentiation between various soft tissue structures. And high contrast is crucial for accurately diagnosing disease. Then multiplanar capabilities, it is a 3D imaging modality which allows visualization in multiple planes. We can see images from axial, coronal, sagittal plane. Thus, we get a comprehensive view of anatomical structure. And we can have detailed evaluation from different perspective of the image. And functional imaging, this is the advancement in MRI, which is not just limited to structural imaging. It also offers functional imaging. There are techniques like diffusion MRI, perfusion MRI, which can assess blood flow and other physiological changes, offering deeper insights into tissues, function, and pathology. All these features make MRI very versatile to use, and it is a very valuable tool. Starting with the history of MRI. Developed in 1970s, MRI has evolved from experimental technique to a critical diagnostic tool, revolutionizing medical imaging with its ability to visualize soft tissue in unprecedented detail. Key milestones in MRI history includes Rotterberg's first human MRI image in 1973, the introduction of commercial MRI scanner in 1980s, and a Nobel Prize in Medicine awarded to Lauterberg and Mansfield in 2003. In 1980s, MRI began to be used for head and neck imaging, and from the 1990s to present, advancement in pulse sequences and techniques have significantly enhanced resolution, scanning speed, improving the clarity of images for the TMJ and salivary glands. Coming to the basic principles of MRI. Now, magnetic resonance imaging, MRI, works by using natural magnetic properties of hydrogen proton. Why hydrogen protons? Because they are abundant in body, because we are mostly made up of water and fat. Hydrogen protons are tiny. See here, you can see hydrogen proton rotating positively charged particles that behave like little magnets with a north and south pole. These protons spin around like a spinning top. You can see my laser spinning top around like spinning top, rotating about 360 degrees around their axis. This spinning motion is what makes them responsive to the external magnetic field. Now, every proton spins at a certain speed, and that speed is known as Larmor frequency. This frequency depends upon the strength of the magnetic field. In summary, MRI takes advantage of the way hydrogen protons behave in a magnetic field, making it great for imaging soft tissues where water and fat are abundant. Now, when patient enters the MRI scanner, so this is the MRI scanner, and this is patient. Hydrogen protons, these are hydrogen protons in the body align with the magnetic field generated by the scanner. Most of these protons align parallel to this strong magnetic field, which runs along the length of patient's head. We call it a Z-axis, typically from head to toe. This magnetic field or Z-axis is sometimes this magnetic field, which is called as B0. Okay, this is resting or equilibrium state. The oral magnetization point towards patient's head along with this Z-axis. This alignment is the foundation of MRI as it sets the stage for capturing detailed images when additional radio frequency pulses are applied to disturb this balance. Once the pulse stops, the proton realigns with B0, emitting signals that our MRI machine captures to create an image. Now, when we see these hydrogen protons, they do not spin synchronously. They individually, they have their own rotation. And this state is known as out of phase state. When we apply radio frequency pulse here, when we apply radio frequency pulse, these protons begin to spin in phase. So these out of phase protons will turn in phase, causing the net magnetization to shift from the Z-axis that is longitudinal plane, to XY axis, that is transverse plane. See, this magnetization shifts from longitudinal to transverse plane. This process is referred to as excitation. Consequently, longitudinal magnetization decreases while transverse magnetization increases. So this longitudinal magnetization, it decreases when they turn into phase, and this increases transverse. The resonance occurs when this frequency is matched. When we initially apply the radio frequency pulse, the hydrogen protons in our body get disturbed and spin in synchronize, causing magnetization move from the vertical to horizontal plane. So here this when radio frequency pulse is on. Now we stop the pulse. Once we stop the applying radio frequency pulse, protons start to relax and return to their original state along the z-axis. During this relaxation, they release energy they had absorbed from the pulse to their surrounding. And now this is T1 recovery graph. On T1 relaxation graph, you see how longitudinal magnetization increases over time as the protons realign with the magnetic field. This graph shows that it takes certain amount of time for protons to return to 63% of their original magnetization. And this 63% is considered as T1 recovery time. This is the T1 number, the 63%. This specific time to reach 63% of original magnetization is specific for each tissue. Different tissues in different body have different T1 time. In summary, T1 relaxation measures how quickly protons realign with the magnetic field after being disturbed, and it helps us to differentiate between different tissue types because of their unique relaxation times. Now, when talking about T2, T2 is transverse. So when we turn off radio frequency pulse, the protons in the transverse plane start to behave differently. Initially, they were spinning in phase, but after the pulse is switched off, they again go out of phase. This change is called dephasing. Okay, this is dephasing. As protons start to lose their synchrony, they are influenced by irregularities of magnetic field. Just think of protons as tiny magnets. These irregularities cause them to spin at different rate and different speed in the dephasing process. So T2 relaxation specifically describes the process in XYZ plane. See, this is XY plane. T1 was in the Z plane and T2 is XY plane. When we talk about T2 relaxation, we are focusing on loss of phase and coherence in the transverse plane. In simpler terms, T2 relaxation measures how quickly protons lose their coordinated spinning after the radio frequency pulse stops. This is particularly useful in highlighting pathologies. So this is the graph. So T1 is recovery and T2 is decay. T1 is recovery of the longitudinal magnetization and T2 is when we what we just have seen has been described in this exponential curve, T2 decay. So this is the T2 decay in the ideal curve, ideal world. However, when we measure it in humans, in the real world, where we find transverse decay is much faster. So this is known as T2 star, because this decay is much quicker and signal reduces to zero faster than it's expected. This is due to effect of the local and external magnetic field inhomogeneity. Although the B0 magnetic field is largely the same throughout, it is not exactly homogeneous, and tissue and other materials within the field will also affect the magnetic field. This variation causes the nuclei to dephase quicker, and this leads to T2 star. Coming to TE and TR, the echo time represents the time between application of radio frequency excitation and the maximum signal obtained. So we apply the pulse and we wait for a signal to come back after it is stopped. So this time is T, the echo time. And the repetition time is between first and when second time radio frequency pulse is applied, that is TR. So this time is TR, this is radio frequency pulse. Radio frequency pulse is applied, then it is stopped. And after we hear echo for the first time, that is TE. And then after some time, when we apply the second radio frequency pulse, the interval between these two radio frequency pulse is TR, or the repetition time. Now putting it all together. Basically, when we are talking about MRI, there are three main components. One is big magnet, induced high power magnetic field. This big magnet generates a strong uniform magnetic field. Second, there is a gradient coil. It modifies the magnetic field to localize the MRI signal by creating variations in the field strength along different axes, allowing for spatial encoding and production of detailed image. So gradient coil helps in localization of image. Third, radio frequency coil. Okay, so radio frequency coil sends radio frequency pulses to excite protons in the tissues and then receive the emitted signal as the protons return to their original state, helping create an image. So whenever a magnet is moved according to law of Faraday, it generates electric current. These protons in the body, they act as tiny magnets, and when radio frequency pulse is applied and then it is stopped, they emit a current. And this frequency, this signal which is emitted by these protons is again captured by the radio frequency coil. So radio frequency coil has two functions. First, generate a current and again capture it after some time. When patient is placed in the magnetic field, their tissues become temporarily magnetized due to proton alignment. This effect is very subtle and disappears when the patient leaves the table. Now, how MRI works? In MRI scan, the focus is primarily on the hydrogen atoms, which are abundant in the body. Normally, these atoms are randomly oriented. So here you can see these are randomly oriented, but when exposed to external magnetic field, they align either in the direction or opposite to the magnetic field. This creates the net magnetization. When the radio frequency pulse is applied, the spins align in the single direction. Now, once again it is turned off, the atoms return to their original state. Okay, so they want to go to their original state, releasing energy in the process. This release energy is detected as signal, which forms the MR image. The magnetic field also causes tissues to resonate as a specific radio frequency, hence the term magnetic resonance imaging. This resonance occurs in specific nuclei, typically protons, within the tissue. The gradient coil's role is essential in determining where the MRI signal is coming from, while the radio frequency coil induces resonance and captures the signal. Now, MRI distinguishes between different tissues because normal and pathological tissues magnetize differently and relax at a varying rate. This helps us to get the contrast that we want. Signal detection by coil. These emitted signals are captured by a receiver coil placed around the body. The coils act as an antenna and detect the small radio frequency signals emitted by relaxing protons. The signal collected from different parts of the body vary in intensity based on the tissue composition, proton density, and relaxation types. Now, these signals which are captured are then converted to digital signals. This radio frequency signals are picked by the coils. Then they are converted to digital converters, which allows MRI system to process and analyze them. To figure out where in body the signal is coming from, okay, the magnetic gradients are applied in three directions, that is X, Y, and Z plane. These gradients allow the MRI system to distinguish between signals from different spatial locations in the body, enabling the creation of images in various planes. Now, what is K-space? The raw MRI signal is first stored in mathematical domain called as K-space. a matrix that holds frequency and spatial information of object being imaged. K-space is like a grid where signal is corrected during scan is placed, but it doesn't actually represent the image, but contains the frequency and phase data that is required to form image. And each point in this K-space corresponds to a specific frequency and phase of the signal related to particular position in patient's body. During the scan, this K-space is filled with data point by point. Okay, so this is how K-space might look, and line by line. The center of K-space here contains low spatial frequency information determining overall image contrast, while the periphery of the K-space, it has finer details like edges, details, sharp transitions. Coming to Fourier transfer and image creation. The data in K-space is not in the form of image. So to convert this data to an recognizable image, the MRI system uses a mathematical operation known as Fourier transform. The Fourier transform translates the frequency and phase information in the K-space into the spatial domain information, turning the data into real-life images which we can identify. And after applying the Fourier transform, the result is 2D or 3D image where pixel intensities correspond to signal strength from various tissues. And different tissues have different signal intensities. Okay, so in MRI, protons in the body absorb and release radio frequency energy as they return to their equilibrium state, emitting signals in the process. These signals are detected by receiver coils positioned around the body, which act as antennas to capture the small radio frequency signal. Then these detected signals are converted into the digital data. Gradients applied during the scan provide spatial encoding, which allows for the localization of these signals within the body. The raw signal data is initially stored in the data matrix or K-space. To create the final image, Fourier transform convert the K-space data into the final image, resulting in the good visual image that we can see and analyze. Coming to again T1. Okay, so T1 or the longitudinal relaxation is the time constant that measures the regrowth of longitudinal magnetization after radiofrequency excitation. Like we said, when the radiofrequency pulse is applied, they flip, all the protons flip, and then they come back to its original position. This process, the T1, is also known as spin lattice relaxation or the thermal relaxation. During T1 relaxation, energy absorbed by the protons is transformed to their surrounding or the lattice. That's why it is spin lattice relaxation. For this energy transfer to occur, stimulation is necessary. This stimulation comes from a transverse magnetic field that fluctuates near the Larmor frequency. Okay, the Larmor frequency is the one where protons resonate in MRI scanner. The source of these fluctuating fields is typical molecular motion of the protons or electrons. T2 or the transverse relaxation, it measures how quickly the transverse magnetization decays or loses its coherence after being disturbed by radio frequency pulse. This is known as spin-spin relaxation. So T2 is spin-spin and T1 is a spin lattice. Unlike T1 relaxation, which involves energy transfer from proton to surrounding tissue, T2 relaxation can happen with or without such energy transfer. T2 relaxation occurs because of interaction between neighboring protons. That's why it is called spin-spin relaxation or disturbance in the local magnetic field, which causes the proton's magnetic moment to gradually lose its alignment and dephase. Although that affects anything that affects T1 can also impact T2 relaxation. T2 can occur independently. Now this is T1 weighted sequence and T2 weighted sequence. T1 weighted sequence is generally used for anatomical abnormalities, atrophy of the cortex, and brainstem. T2 is generally concerned with the severe pathological processes such as edema, necrosis, inflammation. We see better in T2. So these are different signal intensities in each. So how will you decide T1 and T2? T1 scan is white matter appears white. This is T1 weighted image, and dark matter appears dark, and CSF appears dark. So this is very important thing to determine in T1 image. In T2, CSF appears bright and white matters appear dark, dark matter appears bright. Okay, so these are different signal intensities of different tissue. So in T1, air, calcium, cortical bone all appears black, while high signal intensity is shown by fat, blood, gadolinium, even in that is the contrast agent. And in T2 weighted images, air, calcium, everything appears black. Low signal intensity by ligaments, tendons, liver, pancreas, and high signal intensity by the fluids such as CSF, bile. So again, this is a graph of T1 and T2. We can see each, this is the white matter, this is gray matter, and this is CSF. So each has different T1 time. That's why we can see three different tissue and we can appreciate this contrast. CSF takes very short time to recover. That's why it is not bright in T1. While white matter takes a longer time to recover, so it appears bright, okay, in T1. And gray matter has got intermediate time between CSF and white matter. And when we are talking about T2 again, so this is T2 decay. The CSF is showing very slow process. That's why it stays bright. This is gray matter and white matter. White matter decays very fast. This is the graph. Since they all have different T1, T2 times, each tissue, we can see the contrast and we can identify each structure. Now, what is proton density image? Proton density is an MRI technique that highlights the density of protons in tissue. It provides images where contrast is primarily based on number of hydrogen protons. So this is more of a historical importance. It was used previously. It is not used that common these days. It is used, but not as common as T1, T2. So it has both long T and long TR. And it is soft used for soft tissue evaluation, bone marrow assessment, and tumor characters. It helps in assessment of tumor boundaries. It is also used for joint to analyze joints. Now, fluid attenuated inversion recovery, which is FLAIR. FLAIR is also a very important sequence which is used. It is a specialized sequences that is designed to suppress signals from the CSF. By using inversion recovery sequence, these are a specialized type of sequences. FLAIR eliminates the high signal from CSF. So this is T2 weighted and this is T2 FLAIR. You can see the image is similar to T2, but CSF signal is gone in this. FLAIR eliminates the high signal from CSF, allowing the clearer visualization of lesions and abnormalities located in the CSF. This suppression enhances the contrast between brain lesions and surrounding tissues. FLAIR imaging is particularly useful in neuroimaging for detecting subtle lesions that might otherwise be obstructed by CSF. It is also important in the diagnosis of stroke or other brain pathologies. There are a few more additional sequences, that is STIR and fat suppression. STIR is a short T1 inversion recovery. It is specialized technique that again used to suppress fat signal. It effectively nullifies the fat signal while allowing other tissues to be clearly visualized. Whenever we are expecting fat tissue to obscure or interfere with the detection of important structure or pathologies, we can use STIR sequence. Now, we have already covered when to go for MRI and when to go for CT. We mainly use CT because of our interest in heart tissue. But when we want details and refined images of soft tissue, MRI is always preferred. It has advantages that it is non-invasive. It doesn't need any ionizing radiation. Uh, the disadvantage of MRI, it takes longer time and it might be very expensive than CT. There are certain things known as strengths by Tesla rating. If you see MRI scanner, they have different strengths. The 1.5 Tesla is the strength which is generally used in at the most of the centers. It gives good overall imaging quality, widely used in clinical practice for general diagnosis. But now with advancement, 1.5 Tesla scanners are being replaced by 3 Tesla scanners. They have higher resolution images, better signal to noise ratio. So this is the 1.5 Tesla image and this is the 3 Tesla image. You can appreciate the images, the clarity of the image. This is 3 Tesla. But again, there are some articles on how 1.5 Tesla scanner can be improved. But overall, 3 Tesla is better than 1.5 Tesla. Then 7 Tesla and above, they've got exceptional image details. They have superior contrast, generally used for small structures. I have worked with 9.4 Tesla scanner for it is generally used for small animals and preclinical imaging. Uh, so 7 and 9.4 have not in clinical practice now. They might come in near future. So practical consideration is that higher Tesla machines, they provide more detailed images, but may come with increased cost. They might be higher, they might cause higher patient discomfort because longer duration of scans. So this was about basic. Now, I'm more excited to tell you about advanced MRI. These enable MRI to be more useful in different fields, such as cancer diagnostic or treatment response. These techniques like diffusion weighted imaging, also known as DWI, then perfusion weighted imaging, PWI, which is play a crucial roles in diagnosis and management of malignancies. Also, there is one more MRI advancement which is known as functional MRI. They give additional functional images of brain. Now, why to go for diffusion, perfusion, or advanced MRI? Is conventional MRI or CT continue to be the primary imaging modalities for evaluating head and neck cancers. However, both of these modalities rely only on the volumetric and morphological criteria. So we can see the anatomy, but we do not know what is physiology going on and what pathology. It may not be clear, the pathophysiological process. So consequently suffer from low sensitivity or accuracy when making a diagnosis. I will show you some examples where it is more important. Moreover, post-treatment changes can be difficult to separate from tumor recurrence, as both entities may present with the similar imaging features. Now, why these techniques are very important, especially in malignancies, because diffusion weighted and perfusion weighted images are particularly valuable in brain cancers in identifying gliomas, differentiating between high grade and low grade gliomas, and most importantly, determining the treatment response. They can also be similarly used in head neck cancers because this help in detecting primary tumors, assessing metastatic involvement, and also it helps to understand the treatment response. I will show you the example in a while. Now, going to bit details of diffusion MRI, you might all be aware that diffusion phenomena. Self-diffusion is the diffusion of substance in itself. It is the biophysical mechanism. Is based on microscopic random translational motion of water molecules in the biological tissues. So the magnitude of this motion is characterized by apparent. These particles, water particles, are randomly moving, and this is known as Brownian motion. And Brownian motion of water molecules is impeded by the cellular packing. Okay, so cell walls or intercellular organelles or cell membranes, these all prevent this random motion of water. So variation in apparent diffusion coefficient, which is the magnitude of this motion, is the fundamental principle behind the diffusion weighted MRI. And this variation in diffusion coefficient reflects a relation and the alteration and redistribution of water molecules between these intracellular and extracellular components of the tissue. Coming to diffusion weighted, it measures the diffusion of water molecules in tissues, highlighting the areas of restricted or enhanced diffusion. So, how it helps in tumor detection? Diffusion weighted imaging is sensitive to the random water molecules. In malignancies, there is increased cellularity. So, they are tightly packed cancer cells. So, they restrict the water movement of the water molecules within the cell, resulting in lower apparent diffusion coefficient. And thus, it appears hyperintense on diffusion weighted image. That helps in detecting tumors, especially in brain or head and neck region. Then lower diffusion coefficient because of tumor aggressiveness. If the tumor is very aggressive, then there will be high cellularity. High cellularity means cells will be tightly packed with the cells and there will be less motion of water around it. So again, it will have lower ADC value. It might be a representation of aggressiveness of the tumor and assessing treatment response. After treatment, many times the regular follow-up scans are taken, and we are not sure whether if in the follow-up scan there is a new hyperintensity or a new lesion that is apparent on the scan. We are not sure whether this is a recurrence or this is a pseudo progression. I will be talking about that soon. So this diffusion weighted MRI, it helps to determine the new lesion that is apparent in scan, whether it is a new recurrence, new slide, or it is just another pseudo progression. It is not a new lesion. It is just healing lesion. Diffusion weighted MRI can help us determine that. So it can also differentiate it between tumor or infection or whether it is necrosis, depending upon the ADC, that is movement of water molecules within the tissue. Coming to contrast enhanced MRI, there are two types of contrast enhanced MRI. First is dynamic susceptibility contrast, which is one of the exogenous contrast based method. It is real time imaging. It is based on change in magnetic susceptibility. It involves injection of gadolinium and it generates the well-defined bonus. This technique utilizes very rapid imaging to capture the first pass of the contrast agent. So this is also known as bolus tracking MRI. So whenever the contrast agent is injected, the first time it passes through the blood, that time quickly images are taken. That is dynamic susceptibility contrast MRI. Then comes perfusion MRI. It reports to rate of blood delivery to the brain tissue. So it assesses blood flow within the tissue by measuring delivery of contrast agent through vascular system. So whenever a contrast agent is injected, after a while it gets perfused into the different cell tissues, and perfusion MRI can help us detect that. So basically, there are two: dynamic susceptibility contrast and dynamic contrast enhanced, also known as bolus tracking. It is first pass of the contrast and DC accumulates of the contrast agent. And this is T2 and this is T1. Okay. Here when gadolinium passes through the tissue, that time images are taken. Then comes perfusion weighted MRI. It measures blood flow in tissues, which is useful in evaluating tumor vascularity. Generally, because of neoangiogenesis, malignancies are more vascular. So perfusion weighted shows higher signal intensity in these tumors. And also it might helps us to determine which is more aggressive or less aggressive, again monitoring the tumor response, or whether there is stable perfusion or increased perfusion. Increased perfusion might suggest there is recurrence of cancer. So perfusion weighted imaging can help us determine that. So this is T1 and this is T1 with gadolinium. We can see this enhances the blood signal in blood vessels. See, these are the bright signals because of blood vessels. Now, these techniques have applications to evaluate tumor characterization, to study vascular malformation, as it determines the blood vessels and flow patterns. And it can also help to assess the trauma related changes or the inflammatory conditions. Now, orofacial pain is something that we deal regularly in our clinical practice. And at times it can be very challenging to identify whether patient has pain or not. Because assessing pain, it relies on patient describing their own experiences, which can be subjective. So pain is a very subjective phenomena. To address this, we need accurate, non-invasive, safe method for evaluating pain. We do use this pain scale, but it may be unreliable. So functional neuroimaging studies have been used to map brain activity in people with fibromyalgia. Fibromyalgia is a disease where a patient has chronic pain and it is very challenging to condition to treat, and they have pain during both resting and they have these studies were conducted in patients with fibromyalgia in both during resting condition and when patient had pain. And fibromyalgia is linked with abnormal brain activity patterns, so they don't see any abnormality, which is the physical abnormality in patient, but patient still feels pain. So functional neuroimaging can offer an objective and measurable way to assess the fibromyalgia or any other pain. How it works. So functional magnetic resonance imaging, which is fMRI, is the type of magnetic resonance imaging that measures the brain function. So mainly based on blood oxygenation level dependent, that is the bold signal that changes occur as a response to increased neural activity in the brain. However, this is the indirect measure of brain functions. So whenever there is noxious stimulus is applied, there is activation of pain pathways. This results in lighting up of the areas where pain is processed. And thus we can identify that patient has pain. So this is the slide showing how this functional MRI works and how these bold signals are responsible for detection, generation of signal and functional MRI operation. So functional MRI are obsessed on the basis of it based on the principle of neurovascular coupling. When task is performed, such as inducing pain, neurons consume more oxygen locally. Okay, so this is increased neuronal activity, increased blood flow. This causes increase in blood flow, increased cerebral blood volume, resulting in higher production of oxygen atom. Okay, so deoxygenated blood creates local magnetic field variation, leading to rapid magnetic delay, and so T2 star decay. So whenever there is neural activity, there is increased blood flow and increased oxygen metabolism. Increased oxygen metabolism change the magnetic property of the tissue, and this generates signal. It does not measure the neuronal activity directly, but rather detects the related hemodynamic changes. Okay, again, it is done with gradient echoplanar imaging, which shortens the acquisition time. Now we have studied so many sequences, and why multiple MRI sequences are necessary for radiological diagnosis. Okay, while working on my PhD research, I worked on brain cancers and I observed that radiologists always reviewed all the sequences to diagnose the tumors. They never relied just on one sequences. And let's see why it was important to study all the MRI sequences. First, now each MRI sequence has its own function and it gives the valuable information about the pathology that we are studying. When we are starting with T1 weighted image, it provides detailed anatomic information and is excellent for assessing the structure of the tissue, including fat and muscles. It helps in identifying anatomical landmarks and characterizing lesions. Okay, so it is the anatomical scan. When we go for T2 weighted imaging, it highlights edema, fluid accumulation, and this is valuable for detecting pathology in soft tissues. So these are the basic tissue characteristics. Now, when we are going for enhanced lesion detection, other sequences like FLAIR, DWI, and perfusion. So FLAIR specifically suppresses the cerebrospinal fluid to make lesions near CSF appear clearer and useful for detecting lesions which are in vicinity of CSF, and it can be for brain tumors also. Then comes diffusion weighted imaging. It measures the diffusion of water molecules, and it's sensitive to changes in water content or water movement, I would say. Last is perfusion. It gives information about tumor's blood supply, essential for understanding its behavior, whether it is very aggressive, whether it is recurring, and then we can plan treatment accordingly. So each sequence has its unique properties, which helps when all these are combined, we get the best information for the tissue or the pathology. So this is the example where all scans are there. This is odontogenic infection of the right buccal lesion. This is T1 weighted image showing low intensity area. This is T2. We can see the bright CSF signal here. T2 weighted show high signal intensity. So this is T1. It does not show this high signal intensity of infection. It lights up in T2. Then this is T1 inversion recovery. Again, it shows the high signal intensity. This is ADC. Okay, so diffusion map. Okay, diffusion weighted image show high signal intensity. This is diffusion weighted image. And this is another projection where we can see maximum intensity of this. Sorry. Now, this is another example. This is the squamous cell carcinoma of right side of mandible in a 61-year-old male. This is T1 weighted image here, which shows low intensity. T2 image shows a middle signal intensity. This is short inversion recovery image show high signal intensity of the same lesion. This is diffusion weighted image where we can again see high signal intensity area. This is apparent diffusion coefficient map. This shows low signal intensity and maximum intensity projection. Again, diffusion weighted image, it shows lesion in a different way. So we can see the same lesion appears different in different sequences. So we take all the scan, we combine information from what it is seen in each scan, and we come to a diagnosis that this is a particular pathology. Now, when we are giving chemotherapy or any other cancer treatment response is very crucial. We want to know whether patient is responding to whatever treatment we are giving. So whenever treatment has started, there are two possibilities. One is pseudo progression and other is recurrence. Okay. So whenever follow-up scans are taken and you see something new lights up, we want to find out whether it is just a pseudo progression, that is treatment related changes which mimic the tumor progression. So size of tumor increases, but it is not a new lesion. So that's why it is known as pseudo progression. It appears like a progression, but it is not. If patient has pseudo progression, that means patient is responding very well to the therapy. It is treatment-related effect that mimics tumor progression on imaging studies, but it is not due to tumor growth. It occurs after radiation therapy or chemotherapy. While tumor recurrence appears to be reappearance or the continuation of cancer growth after the initial period or improved stability following treatment. So patient improves, but still we see new lesion. We want to find out whether it is because of treatment-related change or it is a new cancer or the recurrence. Okay, so pseudoprogression, they have different appearances on different MRI scans. Okay, so they both increase enhancement on contrast MR. The difference is that they both appear similar, but increase enhancement on contrast MRI, they have no enlargement enhancement on contrast MRI. Okay, and generally, if it is pseudo progression, we do not need to intervene. It resolves over time, while the recurrence might worsen symptoms or clinical deterioration, and it requires further intervention, because if tumor is not responding, we need additional treatment. I'll show you images to explain this in a better way. Now this is the scan. Okay, so you can see the tumor here. Okay, and you can see these are new lesions taken for the follow-up scans. See, this is the lesion that we see. It is 6 months after receiving radiation therapy with concomitant adjacent chemotherapy. Okay, a patient with glioblastoma developed a new heterogeneous mass in this right posterior temporal lobe. Okay, this is the T1 weighted image where it appears bright. However, when we are seeing diffusion weighted image or ADC, it is not lighting up. Okay, it is and also on perfusion. This is the perfusion MRI. We do not see any increased perfusion. So even if it is apparent on this conventional MRI, it is not lighting up in these. So this is likely pseudo progression. But when we are talking about recurrence, this is another lesion. You see, this is very similar on the conventional MRI. It is 5 months after radiotherapy with concomitant and adjuvant chemotherapy was given. This was the patient of glioblastoma, that is brain tumor. And when this is the conventional MRI, this is the diffusion weighted image. You can see it is lighting up in diffusion weighted image as well. It is not decrease ADC, it is not seeing motion, but again on perfusion scan we can see higher blood supply or the hyperperfusion, again which suggests this is a recurrence, and a repeated surgery was performed in this, and which confirmed that this was a recurrence. So this is very crucial when we are assessing the tumor treatment response, especially in brain cancers, and also these are relevant in head neck cancers also, but not that commonly used for orofacial cancers. Uh, these different scans helps us determine the treatment response. So in short, different sequences highlight different aspects. Each MRI sequence provides unique information and highlights the specific tissue characteristics or abnormalities. Relying on just one sequence would limit the ability to fully characterize and diagnose conditions. Then each scan or each sequence provides a complementary information for a thorough radiological assessment. Multiple sequences are needed to get this complete picture of anatomy, pathology, and functional status of the tissue. Combining all these images allow us for more accurate diagnosis and better treatment planning. Many conditions exhibit varying characteristics like we've just seen. Multiple sequences are required to detect and differentiate between different types of abnormalities, and thus they ensure accurate diagnosis, and which leads to obviously better treatment. Now coming to MRI applications in maxillofacial imaging. First and most important is temporomandibular joint. TMJ MRI is the gold standard to understand the soft tissue pathologies of TMJ. Here is the example how TM joint looks. This is the sagittal image. The disc is located in the, see, this is the disc which we can see. This appears dark. Note the bow tie shape of the disc, thicker anterior band which is red, then posterior band is white, and narrow central. This is orange. This is narrow band. This is how it appears, the normal disc. And when patient open mouth, this is the closed mouth position. The similar is the open mouth position. This is a different patient. This is not the same patient. the thinner intermediate, it becomes thinner intermediate disc, and this changes its position. So this is articular eminence, and this is the head of the condyle. This is closed mouth position. When mouth is opened, this condyle moves forward. This is head of the condyle, this is articular eminence, and this is the disc, which is positioned in between the two. Okay, here it is thick band, and here it is thin because of change in position. Okay, and this is temporal lamina. These are the different sequences or the imaging protocol for TMJ imaging in maxilla. Proton density image is also used for TMJ imaging. Now coming to pathology, anterior disc displacement with reduction and without reduction. So we have two different types of anterior disc displacement. One is where patient disc is moved back to its original position, and other where it is not moved back. So this is the, again, sagittal plane proton density image. We can see this is the disc and this is the head of the condyle. This is the closed mouth position where disc is anteriorly positioned. When it is opened, when mouth is open, we can see disc is here. And once it is here, again it move, when mouth is closed, again it moves to the anterior position. So this is with reduction. And anterior displacement without reduction. So this is the sagittal plane image, again proton density. This is the black disc which is seen positioned anteriorly, placed in front of the articular eminence. Okay, here. And even with the mouth open, this is the mouth open, shows it remained displaced and it doesn't change its position. See here, this disc moves to this position, but here, even when mouth is open, it doesn't displaced. Okay, so this is without reduction. This we can diagnose with MRI as disc is clearly seen. Now there are other types of disc displacements also. It is not only anterior disc displacement. Here, this is the posteriorly placed. This is posterior placed displacement. This is the coronal proton density image, and we can see disc is positioned laterally in this. So this is lateral disc displacement. Again, there is a variation. It is pseudo. It is known as pseudo disc. It is closed mouth position, displaced anterior displacement of the disc in front of the mandibular condyle. And it is the thickening of posterior band, which is also known as pseudo disc, which appears like a disc, but it is not a disc. Disc is here, anterior to the condyle. Now, in soft tissue lesions, MRI is highly effective in evaluating soft tissue lesions in maxilla or mandible. This this imaging modality helps differentiating between various types of soft tissue lesions, whether they are benign or malignant lesions. MRI sequences like T1 and T2 or FLAIR can highlight the extent and nature of these lesions, providing critical information for accurate diagnosis and treatment planning. Now, when facial nerve pathologies is essential for assessing facial nerve pathologies like facial nerve paralysis, tumors, using high resolution MRI technique can identify nerve compression, it can identify displacement or infiltration by the tumor. Sequences such as T2 and post-contrast imaging are particularly useful for visualizing nerve abnormalities and determining the cause of facial nerve dysfunction. So it can help us diagnose our diseases. This is the example of a trigeminal nerve schwannoma. We can see this lights up signal. This is abnormality in the brain. Now, MRI, even in cases of maxillofacial trauma, MRI can provide detailed image of soft tissue injuries, bone marrow edema, or generally it gives better visualization of soft tissues. What is the extent of damage? If there are any potential complication, or if there are any foreign objects, MRI can give us this information. Coming to vascular lesions, MRI is instrumental in diagnosing and characterizing vascular lesions in the maxillofacial region. Techniques like contrast enhanced MRI and MR angiography can provide detailed view of blood vessels, which is the feeder vessel, allowing the precise assessment of a vascular lesion and their impact on the surrounding tissue. So this is the mass which shows iso-intense signal on T1 weighted and bright hyper-intense on T2 weighted imaging, which was consistent with the presence of fluid. Okay, they have several vacant spaces. This is the image of hemangioma, and again there are few phleboliths related to this hemangioma. This is seen in this scan. Now, in cases of sinus pathologies, MRI provides detailed images. It is useful in identifying sinus infections, orbital tumors, inflammatory conditions. Sequences like T2 weighted and post contrast images offer clear visualization of these areas, aiding the diagnosis and management of sinus and other disorders. So this is squamous cell carcinoma of left maxillary sinus. So you can see this is the clear sinus on the right, and this is the left sinus. We can see large mass, and this is contrast enhanced CT. It's showing ill demarcated, so it looks very invasive and heterogeneously enhanced bulky mass with extensive bony restriction. See here. Again, MRI is a gold standard for tongue carcinomas. It is crucial for evaluating malignancies of tongue. It provides detailed images of tumor size, extent, involvement of the adjacent structures. T1 weighted and T2 weighted images along with the post-contrast sequences helps in depth of invasion, planning surgical and other therapeutic interventions. MRI's ability to differentiate between tumor types and stages aid in effective treatment planning. But whenever you advise MRI for the tongue malignancy, make sure that you advise it before you take biopsy. Because many times when we take biopsy, there is local area of inflammation and it reduces the quality of image or whatever we want to see in MRI. So if you're sure or if you want to advise patient MRI, make sure that you advise it before you take biopsy, or after biopsy you will have to wait till inflammation reduces and then you can see the image. But it is best you take it before you advise MRI before you take any biopsy in suspected tongue carcinomas. So these are the coronal T2 fat separation image. In the you can see this is the middle third of the oral tongue with early inflammation. Okay, this is the invasion of muscles of the tongue, and this is coronal. This is post contrast image. This is T2 fat suppressor, and this is post contrast image. It is not the same case. It is different case, but it is more advanced. We can see larger lesion invading the floor of the mouth here. Now, salivary glands, MRI has very important role to understand salivary gland diseases. Different MRI sequences are used. T1 weighted imaging provides anatomical details and it helps to identify anatomical abnormalities, structural abnormalities. T2 weighted imaging provides information of fluid and inflammation. Third, flare imaging can enhance visibility of lesion near fluid filled spaces, while post-contrast image can highlight vascular abnormalities and tumor characteristics. Now, this is the T1 image reveals. So this is T1. You can see this hyper intense area. In this is the superficial lobe of parotid gland, and in T2 we can see it has brightened up. Tumor is hyper intense. And this is the T1 with contrast, shows the same image but intense enhancement of the tumor. So this is T1 with contrast. This is the tumor in the saliva parotid gland. MRI has a specific role in salivary gland imaging. First, differentiating between benign or malignant tumor, assess tumor location, extent, Then if we are suspecting salivary stone, it can visualize the stone where conventional methods are inconclusive. It aids in planning surgical or non-surgical intervention. It can detect acute or chronic infection. It identifies abscess formation in the gland, and it can assess the inflammation. Then whether there is sialadenitis or other conditions, it can help. It can also help the pre-surgical planning and also monitoring of the known pathologies. Coming to the very last section, MRI safety and contraindications. First, MRI is overall safe imaging modality, but specific precautions are necessary to ensure the patient safety. These include screening for contraindications, such as presence of any metallic implants or devices that might interfere with the magnetic field. Additionally, patients should be aware of importance of removing all metallic objects before entering the MRI scanner to avoid any potential hazard. Now, patient safety consideration. Ensuring patient safety during MRI involves monitoring patient's comfort and health throughout the procedure. Ask patient has claustrophobia, whether the patient is scared to go into the scanner. This includes managing claustrophobia, monitoring for any adverse reaction. If contrast is injected, whether there is any adverse reaction or patient has well tolerated that contrast, it is very important that we assess that. Ensure proper positioning to prevent any discomfort during the scan. And safety protocols also include emergency procedure in place and trained professional ready to assist. So if by chance there is any adverse reaction, you should have emergency procedure in place and trained personnel to manage the adverse reaction or any emergency situation that comes when we are taking MRI scan. Magnetic field and safety. The MRI scanner's powerful magnetic field can affect metal implants, pacemakers, and other electronic devices. It is crucial to assess that any implanted device for MRI compatibility before scanner. So take proper history. Ask patient whether they have any metal implants, whether they are wearing pacemakers, because if they are, MRI is a contraindication for them. Patients with contraindications, alternative imaging methods may be considered. If the patient has all these, uh, take CT, take contrast enhanced CT or alternative methods, but don't go for an MRI scan. Understanding the magnetic field's interaction with materials ensures safe and effective imaging. Now, what are the contraindications for MRI? First, implanted devices and other metallic devices. So pacemaker, if there are any implants, metallic implants, patients are these patients are contraindications for MRI scan. And if patient has artificial heart valves, don't put patient into MRI scanner. And then unstable patients. So patients, if patient is very unstable, it's in critical condition, it cannot stay stationary or without any movement, don't put patient in the scanner, because patient scan will not be clear if patient doesn't cooperate or he is not in the good senses to stay stable during the procedure. Also, if patient has using some resuscitation equipments, it cannot be put into the scanner. Pregnancy is a relative contraindication due to unknown effects on the fetus. So advise only when it is necessary, or just avoid it during till the patient is pregnant. Then if patient is claustrophobic, severe agitation, it's scared, do not put them in the patient in the scanner. Now many people ask the dental consideration. In general, metal dental restorations and implants do not need to be removed before an MRI scan. The most modern dental materials are compatible with an MRI, and their presence usually does not interfere with the imaging process. So it is not important to remove them. It is not necessary to remove them. However, it's important to consider few points which I will be mentioning. First, type of metal. Non-ferromagnetic materials used in dental restoration like titanium are typically MRI compatible. However, some or older certain types of material might affect the image quality, or it causes artifacts. Like we have metal artifacts in CT, we have metal artifacts in MRI as well. Large metal objects or certain dental implants, they may interfere with the image quality. And if you inform it to the technician beforehand, they might use some algorithms to reduce the artifacts caused by these. Then informing, they can make necessary changes. These technicians can make necessary changes. While it is generally not necessary to remove dental restoration, it is important to provide information about them to the technology technicians which are there, so that we can get better images. If there are any loose crowns, then either cement it or remove them. Do not keep any loose crowns in the mouth when patient is going for MRI. Coming to the limitation of MRI, while MRI is a powerful imaging tool, it has several limitations that can impact its effectiveness. First, it is less effective in imaging structures with low contrast. It is not very much recommended for bone. Then MRI scan can be affected by metal artifacts or other metallic objects. It has very high cost and scan duration is long. Patient has to stay stable and steady during a long duration of scan. Uh, it has contraindication for certain devices and it cannot be used for patients with claustrophobia. Future directions and innovations. So future advancement include high resolution imaging that provides greater detail, functional MRI to understand the brain functions. Then artificial intelligence will revolutionize imaging interpretation. AI-driven tool will enable automated and more accurate image analysis. It will also assist in forecasting disease progression, which is upcoming thing. Then there are advanced contrast agent which provide enhanced tissue differentiation. They are trying to make portable and accessible MRI. But again, it is all future development and they are focusing on getting personalized MRI. Dental MRI, one of the most exciting thing in dentistry, and it has been introduced by Magnetome. It is significant advancement in dental imaging. It is not widely available. This innovative system is designed to enhance dentomaxillofacial diagnostic by providing detailed soft tissue imaging, and it does not have any ionizing radiation. It offers superior visualization of soft tissues. This is not yet completely widely acceptable, but this is potential future of MRI in dentistry. This hopefully this will be a small machine which can be used for dental office, but let's see how it goes. Coming to conclusion, MRI is vital tool in maxillofacial imaging. It offers unmatched soft tissue contrast detail and anatomic visualization. It plays a crucial role in diagnosing and managing various maxillofacial pathologies, including soft tissue lesions, salivary gland disorders, facial nerve pathologies, trauma, malignancy, and despite its limitation, such as potential metal artifact, it has ability to provide comprehensive and high resolution images. By understanding the strength and limitation of MRI, clinicians can make more informed decisions and optimize patient care in the field of maxillofacial imaging. So take home messages. The key takeaway from today's presentation is that MRI is an indispensable modality for evaluating maxillofacial conditions due to its superior image capabilities and detailed soft tissue resolution. It is essential to leverage MRI strength while being mindful of limitation to provide best possible care of the patients. Understanding when and how to use MRI effectively will enhance diagnostic outcomes and contribute to more precise treatment planning in maxillofacial imaging. I have given references at each slide. However, these are the additional references if anybody would like to read. Okay, thank you for your patience and attention. Presenting the basics of MRI in a short time was quite a challenge, but I hope you found it useful and easy to understand. I appreciate your time and I hope this will help you during your exam.